Hello and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. We've got a great episode for you today. Our topic is tools for personalized theranostics, and we've got a really great panel that I'm excited to introduce for you. Our first guest is Dr. Ravi Patel. He is Assistant Professor of Radiation Oncology at UPMC Hillman Cancer Center in Pittsburgh, Pennsylvania. We also have Dr. Louise Emmett. She is Director of Theranostics and Nuclear Medicine at St. Vincent's Hospital in Sydney, Australia. And we round out our panel with Dr. Michael Hofman. He leads the Prostate Cancer Theranostics and Imaging Center of Excellence at Peter MacCallum Cancer Center in Melbourne, Australia. Everybody, thanks for being with us today.
Thanks.
Pleasure.
Thank you.
Great. So let's start with introductions. Dr. Patel, can you share a little bit about yourself and your current clinical practice?
Yeah, thank you for having me here. I'm a physician scientist at Pittsburgh, and I have a research lab where I do preclinical research in radiopharmaceutical therapies. And I also have a clinical practice where I specialize in the treatment of skin cancers and GU malignancies, where I also give external beam radiation. But I've also recently started our Pluvicto program and work on radiopharmaceuticals for GU malignancies, including radium and lutetium-based compounds.
Very good. Dr. Emmett, how about you?
Hi, so I'm a nuclear medicine physician, and I work at St. Vincent's Hospital in Sydney running the Theranostics and Nuclear Medicine department. So we're heavily involved both with imaging and therapy of a range of cancers. And it's been a great journey in Australia in the last few years where we've been running multiple national trials together. And it's been an exciting time in theranostics.
Very good. Dr. Hofman, how about you?
Yeah, I'm a nuclear medicine specialist working in a large cancer center. In our center, we've been doing lutetium theranostics actually for almost 20 years, since 2005. And we have a very large imaging program with PET-CT. We do around 50 PET scans every day, and a very large theranostics program. This year, we'll do over 1,000 lutetium treatments. So it keeps us very busy. There's lots of patient consultations involved in that as well. And being in a bit of an academic environment, research is a big part of my job as well.
Very good. So let's talk a little bit about exactly what theranostics is. I think most of our audience kind of has a good idea, but Dr. Emmett, can you give us an idea of what theranostics is and maybe what some of the advantages are and why you're excited about it?
Yeah, so really theranostics embodies personalized medicine, that idea of targeting the cancer cell and then treating it specifically with an agent that can be both highly effective but also have minimal toxicity. And with theranostics, what it is, it's really injected radiation using small proteins that target receptors on the cancer cell surface. So instead of giving external beam radiation using large machines, what we do is we actually inject the radiation with a very small protein attached that finds the cancer cell, enters the cancer cell, and then irradiates the cancer cell from within. So it really does embody personalized medicine. We can do imaging scans that can identify whether the target is present and whether it's present at an adequate level in the cancer cell, and then we can treat. We can unclip the imaging radionuclide warhead, clip on the therapy, and then treat that cancer. So I'm very excited about theranostics. I really think it is great in terms of personalization and moving cancer treatments away from broad systemic therapies.
Yeah. Dr. Patel, what are some of the reasons why you're excited about theranostics, and what are some of the advantages that you feel like it has over some other forms of cancer treatment?
Yeah, no, I am a radiation oncologist, where most radiation oncologists give external beam radiation. And one of the issues with external beam is it's a localized therapy. You can't give it to broad disease or widely metastatic disease. And that's what most of our patients eventually progress to. So as a radiation oncologist, being able to treat patients with metastatic cancer, offering solutions to deliver radiation to widespread disease, I think that's really been a game changer with these new therapies, especially for prostate cancer and neuroendocrine tumors. So for me, that's been why I got interested in this area.
Yeah. Now, Dr. Hofman, you mentioned that you've been doing theranostics therapy for 20 years. What were some of the reasons why you got excited about it so early?
Yeah, look, I think I was lucky as a young clinician, one, to move into a center where lutetium dotatate treatment for neuroendocrine tumors was already happening. But I was attracted to that center because it can get a little bit boring as a radiologist or nuclear medicine specialist, just reporting scans all day in a dark room. So it is nice to have a bit of variety and switching between PET-CT reporting, nuclear medicine reporting, but adding in therapy makes your day very interesting. It's also just really rewarding therapy. I mean, these treatments really do work and they don't have a lot of toxicities. So we see a lot of patient benefits, symptom improvements, and tracking and getting to know a patient over time. It's a really rewarding part of our practice.
Yeah. What are some of the clinical applications that you're finding theranostics is most suitable for?
Yeah, look, for us, it's changed over time. When I trained, it was thyroid cancer. Then when I joined Peter Mac, it was clearly neuroendocrine tumors, and now it's prostate cancer. So prostate cancer would make up 3/4 of our theranostics program today using lutetium PSMA. But I think, as I've seen in our center, this is going to change. There are new molecules coming. It's going to evolve. But as of today, I think globally prostate cancer would be clearly number one. This is a major cause of death in men in most countries. So it's a common cancer. Now, some people have a misconception that many people die with prostate cancer rather than from it, but the lethal variety of metastatic castration-resistant prostate cancer is really very nasty, and this is a really good new treatment.
Now, the Imaging Wire is a radiology publication, and so most of our viewers are interested in imaging. And so imaging has a pretty important role to play in monitoring therapy. Dr. Hofman, can you talk about the role of imaging in theranostics and what role it plays?
Yeah, absolutely. Look, I think it's totally critical. And one of the great things about theranostics, as the word implies, the thera is the therapy, but the nostics is the diagnostics. And you can't really separate the two if you want to do high quality theranostics. So imaging, it forms, every step of the journey. Is the patient suitable? You'll have a PET scan, a PSMA PET scan in the setting of prostate cancer, but you need to integrate that with a contrast-enhanced CT or an FDG or other modalities. So there's a lot of multimodal imaging and merging them all to determine, is the patient suitable for treatment. For prostate cancer with PSMA, this is also for diagnosis, merging with multiparametric MRI. So you really need good software tools to do that. And then when we're treating patients, we image them afterwards as a routine. So this is post-therapy SPECT CT. And we need new tools to do this and to quantify it and to merge the PET CT with the SPECT CT and the quantification. And, this is where we find some of these new software tools really critical for our practice.
Great. And we'll talk about some of those in a minute. Dr. Emmett, what are some of your thoughts on the role imaging plays with theranostics?
Well, I totally agree with Michael. I mean, we use imaging continuously with theranostics. See it to treat it is the mantra with theranostics. And basically, we need to know whether the target is present. We need to know when we're using screening imaging, we need to know how often the cancer does not have the target and won't respond. And then on treatment, imaging is extremely important. So we use SPECT CT a lot, like Michael does. We also use diagnostic CT a lot. We merge all of these modalities together. And it's becoming increasingly evident that quantitative analysis is a really important tool in terms of accurately identifying whether patients are progressing or not progressing. So personalizing treatments on a patient-by-patient basis is very imaging dependent.
Dr. Patel, where do you see image monitoring going over, say, the next 5 years or so?
Yeah, no, I agree with both my colleagues. I think that it's vital. I think we've been a little bit behind in the U.S. compared to Australia in incorporating post-therapy imaging with all of our theranostics. But more and more centers, including us, we do post-therapy imaging after each cycle of treatment. And you do see that the patient's tumor can respond. You can catch early progression. You can decide whether to switch therapy. Additionally, as a radiation oncologist, one of the things I'm interested in is, let's say there's a heterogeneous response where some sites are going away while maybe one site is increasing. I can hit that with external beam radiation or a local therapy. So there's ways we as physicians can intervene if we use this imaging. And this is really unique compared to other systemic drugs like chemotherapy. You give chemotherapy for several cycles and you don't know if it's working. While with this, after each treatment, we can say, yes, it's getting to the tumor. No, it's not.
I actually want to add to that. I think that using imaging with SPECT-CT after each treatment, instead of just using the PSA, gives you so much more information about what the pattern of progression or response is. And we do that all the time. If you have just one site that is progressing, then that is a great candidate for SBRT consideration if they're responding everywhere else. So I really do think it helps nuance what you do.
Now, Dr. Hofman, let's say you have a patient who's responding or maybe not responding to the Theranostics treatment. What's the best way to communicate with them, and how to interpret findings with patients?
Yeah, that's a great question. Look, I think practices differ quite a lot here around the world, even within each country. In our centre, we are quite hands-on. So we are seeing the patients and showing the patients their images all the way through the treatment, from the beginning to after each treatment. So we are not just administering the therapy. And I can tell you the patients love seeing their imaging. And what's striking is often patients have been under the care of oncologists, urologists, radiation oncologists for a very long time before they come for the Theranostics treatment, because these are not first-line treatments today. And often patients have never seen their images. They've just been told their tumour has spread, but they can't visualize it. One, I always check with patients, do they want to see their images? Because some patients just don't want to, and that's fine. I think it's important to check. But 90% of patients do want to see their images, and they like that we can do both. We can take them through their images and also treat them. And we can spend the time to do that. And when they're on therapy, fortunately, these treatments work very well. So often we're delivering good news, showing the response. And these images are really easy to interpret. I think these PET and SPECT images, the tumor to background contrast, the rotating MIPS, the way we have the color, it's quite intuitive. So patients can understand these images. And I can tell you they really value seeing their images, even when things are going bad. They've got pain here. Now they understand why they've got pain. They've got a huge burden of disease. They can realize, what might be coming. So I think this is a critical role where we can bridge this gap between radiology and a little bit of medical oncology. Sometimes I like to think of ourselves as, nuclear oncologists, because we do bridge that gap. And you develop that expertise over time as you start doing these treatments.
Yeah. Now, let's shift a little bit to workflow, because it maybe can be challenging to maybe adopt Theranostics and integrating post-therapy imaging into your practice. Dr. Patel, what sort of challenges have you encountered, and what are some of the ways that you overcome them?
Yeah, so in the U.S., I would say it's not standard that every center does post-therapy imaging. I think we've kind of conveyed why it's so vital and important. For us, one of the challenges is that, some of the equipment, we're a big network. You have old SPECT-CT scanners that take a long time to scan. Often these, some of your patients are frail. They have metastatic cancer. They've been through many lines of treatment. Lying on a SPECT scanner table for 45 minutes can be harder and challenging for them. Other challenges include that oftentimes Theranostic centers are at big academic centers. And many of your patients are coming from rural areas or community sites. I have patients sometimes driving 3-4 hours one way to get this treatment. And we usually do our post-therapy imaging not right after the injection, but we do it a few days afterwards, so we get better imaging of the tumor. And so asking them to make that drive can be challenging. But when we communicate with them, show them why this is important, show them how their disease responds, they see the importance of it, and they were able to get this imaging and tailor treatment specific for the patient.
No, so much of radiology is becoming software-based, and vendors are developing and researchers are developing software-based tools for helping manage a lot of these complex cases and complex conditions that we see. Dr. Emmett, can you talk a little bit about the software tools that are available for Theranostics and what kind of tools that you're currently using?
So there's a number of tools that are available. None of them are really to the point where there's a one-button push. So we don't have a quantitative software which just flicks up next to the radiologist and shows what the total tumor volume is, where they've accurately identified all the tumor sites, and where you get an accurate, quantitative assessment of how that patient is going, either for screening or for treatment response. This is really something that's quite urgent at the moment, and I know that software companies are working on it. We use MIM software in our department for quantitation, and it is getting closer in terms of trying to automate what it's doing. But it still requires quite a lot of work in terms of identifying, making sure that the lesions are correct. So we have a leap that we need to do between now, where it will take 5 or 10 minutes to correct that image, and what we need, which is a quantitative image that comes up onto the screen right next to the image that the patient, that is being reported by the radiologist or the nuclear medicine physician, so they can use it as a tool without having to spend too much time. So I think that the tools are close. They're very useful. They've been demonstrated to have great value in research for prognostic and predictive value for the patient, but we need to make it better. We need to go that next step for quantitation.
Dr. Hofman, can you comment a little bit about software tools? Are you also using MIM in your practice?
Yeah, we've been a long time MIM user and in our center. Look, I started using MIM actually in 2010. It's quite some time ago. And that was initially for research indications. I had some complex needs around actually sort of dosimetry type stuff and complex image analysis. And really none of the software could do it. So we started with a single MIM license for this quantification of complex images, and we just loved the interface and how smooth it was, not just for this complex dosimetry or quantification, but just for a routine PET-CT or SPECT-CT report. So when we moved to our new department in 2016, around 8 years ago, we transferred all our reporting workstations across to MIM. And, we have like 15 nuclear medicine specialists. So it's a big department and we all just use MIM. And one of the advantages is we've got various equipment from different manufacturers and they all come with their reporting platforms. And we don't want to change software every time we report a scan off a different platform. We want like a vendor neutral approach. And MIM is just fantastic at this. It doesn't matter what scanner it's coming off. You get a new scanner in 5 years' time, you don't want to learn a new software package. But I would say it's just so much more efficient. I'm a bit of a IT guru, so it's easy for me to adjust, but there are many colleagues. And it only took them a week or two to adjust to MIM. And the feedback early on in 2016 was, we can report an extra 2 PET scans per day with this software. It's just so much faster, easier to use. I can merge images across modalities so much faster. So there's a huge efficiency improvement there. So this is on the PET-CT side, but when you're doing SPECT-CT after a therapy, you may want to have the baseline PET-CT and now the post-treatment scan. You want those to open up, link seamlessly, quickly. And really, MIM's about the only software package that does this quickly. And, in reality, when I'm on a day of reporting, it can be 8 or 10 hours sitting in front of MIM. So I like to joke that on many days I spend more time with MIM than I do with my kids. So you do want to be using the best software package, and having played with all the various packages across the market, MIM is just really a leap ahead.
Yeah. Dr. Patel, can you share a little bit about your experience with some of the software tools and how and the value you find from them?
Yeah. So I mainly use software tools for dosimetry. I don't read PET or SPECT scans, but really this has been a relatively new area, developing software tools to measure radiopharmaceutical dose. And there's very few vendors. And I think the MIM software MRT package has really helped our practice incorporate dosimetry into patient treatments. And we find it very valuable. It affects patient care. Sometimes the SPECT-CT read from our radiologist or nuclear medicine physician will say, there's pretty equivocal uptake, but when you actually do the dose calculation, you see that, hey, that maybe the dose to the tumor is pretty low or lower than normal tissues, and it makes the decision of whether to continue treatment.
I want to add to that. I think so. We've talked about MIM for just reporting, as Michael does on a daily basis. But one of the things that's very important when you're looking at treatment response is we quantify volume. Not so much dose delivered, but actually change in volume in the patient is very, very important in terms of identifying how they're going and whether you should continue treatment. And MIM really has one of the best abilities to do that. It just needs to be automated better.
Yeah, another aspect of these tools is accessibility. And many of these tools run on dedicated workstations. So they need to be in a particular room, or they run off a server in the hospital, and there's limited accessibility to that server. And one of the advantages of MIM is it runs as both a thin or a thick client. So in our center, we can access MIM on any computer in the hospital. That means we can be in a reporting room, or we can be in a consultation room, or we can be in our tumor board meeting, and we can show the dosimetry analysis, PET SPECT in all these various formats, and in COVID-19, the home reporting aspect as well. So it's really very flexible software in this regard.
Very good. So Dr. Patel, you're a radiation oncologist, and Theranostics kind of combines radiation oncology and nuclear medicine a little bit. How can these two disciplines collaborate to optimize Theranostics care? Do you have any examples of effective collaborations between these two different departments?
Yeah, no. So, I think it's somewhat country dependent. In some countries, nuclear medicine physicians only do Theranostics, while in other countries, radiation oncology does more of it. I think in the US, we both share this space. And there's always this idea of, this is my territory, why is someone else doing it? And I think, at least personally, I think that's the wrong approach, whether for radiation oncology or nuclear medicine. Really, this is a growing field. It's growing faster than we have enough. We don't have enough physicians really to take a lead in this area. There's so many new agents coming, and there's a lot of work to do. So just to tackle all the new agents and the expansion of Theranostics, we need as many physicians as possible. At UPMC, we both nuclear medicine and radiation oncology works together. We both are authorized users. We both treat patients, see consults. I think definitely on the imaging side, nuclear medicine, I talk to my nuclear medicine physicians all the time. What do they think about disease progression when we do these post-therapy imaging? They'll also come to me for their patients that, hey, I give SBRT to a lesion that's progressing? I think we're all stronger when we work together. We all have different areas that we specialize in. And it's not just nuclear medicine, radiation oncology. Urology is sometimes involved for surgical or cryoablation. We also have medical oncology. A lot of these patients have heme toxicities where we need to start end plates for low platelets, blood transfusion. Really, it's a multidisciplinary treatment, and it's not just one group.
Dr. Hofman, Dr. Emmett, what's the situation like in Australia?
Yeah, look, I want to add to that and just agree. I think in Australia, the actual administration, it's a little bit more of a nuclear medicine type specialty, but we work very closely with our radiation oncology colleagues. I think the radiobiology, we have a lot to learn from our radiation oncology colleagues. They also have more experience in the patient care. So we work very closely, both on a clinical and a research perspective. So we have research labs as well, and some of the radiobiology is run by our radiation oncologists. And our very first protocol of lutetium PSMA, which was 2015, was co-written by myself and one of our radiation oncology colleagues, John Violet, and we wrote this protocol together. And it was immensely fruitful to have the two specialties working seamlessly to try to understand what we're doing and the best way to approach this. And there's metastasis-directed therapy with stereotactic radiotherapy and external beam. We have trials running also with Louise where we are combining SABR and Theranostics. So on so many levels, from clinical practice back down to research and trying to understand how to optimize these therapies, there's a huge value in working together.
Great. Dr. Emmett, do you see the disciplines playing nicely together?
Oh, yeah, absolutely. And I have to say that Australia's done such a great job in that. But I would also talk about multidisciplinary management. So we co-share each one of our patients with a medical oncologist. Actually, we have a medical oncologist involved in every single one of our patients. We have radiation oncology involved as well. But these patients are complex. Lutetium or actinium or whatever theranostic agent you're going to be using is only one of many therapies these patients will receive in their cancer journey. They need to have their clinicians understand their entire needs. And so holistic medicine for these patients is multidisciplinary. And I think we all do that.
Yeah. So we're starting to draw to the end of our time, but I'd like to maybe finish by looking forward a little bit. Dr. Hofman, what are some of the challenges that you foresee for Theranostics over the next 5 years, and what role can technology like software and maybe even AI play in overcoming some of these challenges?
Yeah, it's a rapidly evolving field. For many centres, this will be new. It'll be something that they're just starting to do, so they need to upskill. So I think the first major challenge for many centres will be acquiring the skills. And I think that does require just some time and effort. So as part of a fellowship or as part of a sabbatical, to go to a centre like people on this call to learn and see how it's done. I think that's a critical component. I think you do need to learn how to use these new software tools, particularly how to get comfortable with post-therapy imaging. This will be new for many people. Like anything, it's not hard, but you do need to upskill. You don't want to treat the first patient and learn as you go. You do want to go and upskill. In Australia, we've done some major efforts in this regards. So we've got some credentialing procedures, similar to what you might do if you need to report a PET CT or a multiparametric MRI, where our association has come up with some minimum standards, and you can, get your training accredited. And we think this is an important aspect other countries might like to follow. I think that's reassuring for many people, from the regulators to the patients, that yes, I'm going to see a centre and someone that has the necessary skills, the necessary software, everything to do this in a professional manner.
Yeah, Dr. Patel, what gets you excited about Theranostics in the next 5 years or so?
Yeah, so definitely, like in the U.S., alpha therapies are being more and more. There's more trials around those. We've primarily been using lutetium or radium previously, but there's a lot of new isotopes, and whether it's actinium, lead, astatine, there's really been a push for more alpha therapies. This is kind of, as a researcher, I'm also very interested in combination therapies with other systemic therapies. We've had really big gains with Theranostics and many of these radiopharmaceuticals, where we've extended patient survival, had long-term durable responses. But we're curing relatively few patients, and it's really hard to cure someone with metastatic cancer. So personally, I'm very interested with combination with immunotherapy. My lab does a lot of work with radiopharmaceutical therapy and cellular therapy, such as CAR T cells. If we can get to a point of minimal residual disease with these radiopharmaceuticals, maybe we can use a cellular therapy approach to tackle the very last bit and potentially cure metastatic cancer. I think that's really the long-term goal for all of us.
Very good. Dr. Emmett, what do you get excited about when you look at Theranostics' future over the next, say, 5 years?
Lots of things. So it's like watching a flower unfold. So many things happening. And like Ravi was saying, I'm excited. I'm a science geek. All right. So I'm excited about the fact that I'm injecting copper, lead, actinium, and lutetium early next year in patients for therapies. It's crazy. But I guess what I really want to see happen in the next 5 years is for us to firm up our ability to quantify our treatment response imaging, and to make it easier for people to do it. So I want to see post-treatment imaging used across the world. I want to make it easy for everyone to use. I want the software to be accessible and to work without a lot of input so that you need to be an academic to be able to use it. That's really what I want.
Dr. Emmett, do you have any advice for centers that are thinking about starting up a Theranostics program?
Look, I'd say yes, do it. It's great for your patients. It's fascinating work for yourself, and it's a field that's going to be rapidly expanding, and it can only be good for your institution. Obviously, you need appropriate governance rules and space, and you need to make sure that you do it in a very careful way. So you're going to need education. You're going to need to make sure that you don't learn on your first patients, as Michael was saying. But I would say if you're thinking of doing it, really, it's a great choice.
Dr. Patel, what kind of advice would you have for someone thinking about starting a Theranostics program?
Yeah, no. So I'm at a main academic center, but we have 26 satellites at community sites. And so we're actively working on getting Theranostics to where people live. Not everyone lives in the big city close to an academic center. As I said, many patients drive up to 4 hours. There's a lot of challenges, but ultimately it's the right thing to do for our patients. We want to be able to offer these treatments where they live. And really, there's been a big push by our department. I think that that's the future of most cancer care that starts at an academic big center, but then it needs to get to community sites. And so, there are challenges, but you can overcome them. And in the end, it will help your patients. So I'd say go for it. And there's many of us who are willing to help them get there.
Very good. Dr. Hofman, what advice would you have for someone thinking about starting a Theranostics program?
Yeah, look, there's a lot to learn, but like anything, you can upskill and get good at it. It is a little bit of a different world, and you do need a certain amount of infrastructure, which includes software tools like me, but it also includes some physical infrastructure so that you can treat patients safely with appropriate radiation protection precautions. So you may need some infrastructure investment in your center to enable this treatment. If you just want to treat small volumes, you may not need too much infrastructure. But if you really want to ramp up, this requires a significant infrastructure investment from your center. I think this is the future. If we think about just about any hospital delivering cancer care, it will have a chemotherapy day unit where the chemotherapy is given. That's a standard of care. It's normal everywhere. But for Theranostics, this is not yet the case. But I think if we fast forward 5-10 years, this will be the case. Every hospital will have a Theranostics treatment facility. It'll be a standard part of a cancer care center. You'll have external beam as well, a chemotherapy day unit, but the Theranostics center will be a key component of that.
Very good. Well, I look forward to seeing that future. Some great discussion today. I'd like to thank Dr. Ravi Patel, Dr. Louise Emmett, and Dr. Michael Hofman for being with us today. Everyone, thanks so much for the time. We really enjoyed the discussion.
My pleasure.
Pleasure.
Thanks.
Signing off for the Imaging Wire, my name is Brian Casey.